Good afternoon, everyone. It's a pleasure to be hosting today's webinar titled Managing Your Scleroderma and Raynaud's Medications. I'm very pleased to be joined by our expert speaker, Aoife Tynan. Aoife, how are you doing?
Hi, Zober. Yes, very good. Looking forward to the session. Thank you.
It's an absolute pleasure having you on. I can already see we've got 14 attendees and it's growing. So we've got Anita that's joined us. We have Janine, Liz, Ruth, Sarah, and it's fast growing. We're now on 25. So hopefully we can get those numbers up in the coming minutes. A little bit of information about Aoife is that she is a rheumatology pharmacist at the Royal Free Hospital in London. She works alongside the multidisciplinary team to support with medication-related inquiries. This involves providing advice to rheumatology patients, including our scleroderma patients. She also has an interest in biologic therapy and works closely with local and national commissioning bodies to produce guidelines to support safe use of biologics for rheumatology conditions. So just to let everybody know about the structure of the webinar, it will be split into two parts as always. Part one will be the presentation by Aoife, and then part two will be the Q&A, where we will give you all the opportunities to send in your questions, live and interactive, for me to put forward to Aoife. If you are finding these webinars to be very helpful and you'd like to support future webinars, you can do so by making a donation of £5. You can do so by texting SRUK webinar to 70450 and text costs £5 plus one standard rate message. Once again, that's SRUK webinar to 70450. And I'll put that in the chat for you all to see. But otherwise, we've now got up to 35 participants and it's still growing. And I'm very happy to now hand over to you, Aoife.
Great, thanks, Zober, and thanks to SRUK for letting me speak today. It's hopefully it'll be quite informative. The way I think, as Zober had said, we've planned the session is just I'll give a brief overview of kind of medicines that we use in the management of scleroderma and Raynaud's, which will be very general, but hopefully we'll give you an idea of what we use, why we use them, some of the common side effects we see, and then how to manage them, but also some things about the about monitoring and what the expectations of the medicines that we use, and then hopefully bring if you do have specific questions, then we'll bring that in through in the second session. So definitely please send your questions through. That'd be really helpful. So just as an overview of what I'm going to talk about, or how I've set the structure of the talk, is I'm going to focus a bit around the management of Raynaud's medicines and treatment in digital ulcers. But I think it's really important, and like the first strategy of any treatment plan should be looking at non-pharmacological treatment, and we shouldn't be jumping straight into drugs. And this is particularly so for Raynaud's. For the first slide, I'm just going to talk about what non-pharmacological strategies for managing Raynaud's, which some of you may be aware of already, but it's just to bring that to the front again, and just to mention as well before we go on to talking about drug treatments that we use. I'll start talking about the common treatments that we use first line in Raynaud's treatment, and then stepping on for the more further therapies that we use when we get to like where you've got where maybe treatments may not be working, or the first line treatments may not be working, or for patients that if you get digital ulcers, that you might look at other strategies for treating that. I'm then going to shift away a bit from the Raynaud's and the digital ulcers to look at other treatments that we use in scleroderma, because a lot of and this is possibly more so for diffuse scleroderma, where you get like organ involvement, but we do use it we quite commonly use systemic immunomodulatory drugs to dampen down the inflammatory response in the system. So we'll touch a bit on that. And then just finally, we'll talk about things like the gut and skin complications, which are really common in scleroderma, and look at like some of the drugs that we use to treat that. And then I'll finish by looking at just as a broader overview of like other drug management therapies or other things to think about when you're thinking about managing your medicines for your Raynaud's and Scleroderma. So as I touched on the start, I just think in terms of Raynaud's treatments, we all the idea of Raynaud's is that you get vasospasms or you get in the peripheral arteries. So we're looking at mechanisms to prevent that or stop that happening, to prevent the symptoms and the frequency of attacks of Raynaud's. And before we go on to using drug treatments, there's lifestyle measures that can be targeted, and these are usually the first line measures that we would use to start on for the treatment of Raynaud's. So things like avoiding your cold or ambient temperatures and avoiding extremes like going from a hot room to really cold outside without having the necessarily without having layers on can act as a trigger and can increase your attacks of Raynaud's. And similarly, of the same vein, like keeping warm and making sure you're using lots of layers and gloves and woolly socks, etc., to keep your extremities warm to avoid the attacks in the first place. If you smoke, I mean, one of the best things you can do is to stop smoking. It's not just for your Raynaud's, but for other complications with Scleroderma, like your lung involvement, but it's really important for Raynaud's. Because smoking can reduce the peripheral flow of blood to the extremities and reduce that circulation, which can further exacerbate your Raynaud's. So lots of there's lots of help out there if you do want to if you do need help to stop smoking. It's really hard to do it on your own. If you link in with any GPs or community pharmacies, will have links to stop smoking services and the options that are available. There's a wide variety of options available, from like psychological support to drug treatments with nicotine replacement, and there's lots of nicotine replacement products that are available, and your community pharmacy is really well placed to help you decide on the best option for you. But there is support there, so I would say you use what you use that as well. Other measures that we would use are, say, to help just generally, if you can, to avoid repeated trauma to the fingertips or the sensitive areas which might exacerbate the Raynaud's. I know it's not always easy, but to try control or limit stressful situations, because stress can act as a trigger for Raynaud's. And lastly, to do like gentle exercise, which can help improve the circulation and help prevention of Raynaud's disease. The other thing that's always worth considering, which if you aren't sure, it's worth checking with your pharmacist or your GP can help you if you're on drugs that may exacerbate Raynaud's. So in Raynaud's, we're trying to open up or increase the perfusion of blood into the peripheries, or dilate or open up the blood vessels. So counterintuitively, if you've got drugs that are doing the opposite of this, then this can worsen or exacerbate your Raynaud's symptoms. And drugs that we commonly see or that are commonly prescribed that might contribute to this are things like beta blockers. But there is a wide variety of reasons why people might need to be on beta blockers for heart conditions. So do talk to your GP if you're on them and have Raynaud's, and they may be able to think of alternatives in conjunction rather than stopping them completely without medical advice. But they can exacerbate Raynaud's symptoms because they vasoconstrict. The other drugs that we commonly see are things like pseudoephedrine, which can act as a vasoconstrictor. And this is, you see pseudoephedrine is commonly in cold medications, and you can buy it from your chemist. But it can be an ingredient in some of those cough and cold mixtures, so it's worth checking out. And that they can cause vasoconstriction, which can exacerbate your Raynaud's. And sumatriptan is just another example of one. Again, it's commonly used for migraines, but it can cause vasoconstriction. So if you find that that's exacerbating your Raynaud's, you may want to think of alternatives with your GP or pharmacist as well, who are there to support. So that leads on, if lifestyle measures aren't working, or if you're still seeing an increase in attacks and you've tried all of this, then absolutely drug therapy would be your next line treatment option.
Sorry, Aoife, can I just
Yeah.
get you to go into presentation mode?
Oh, yes, sorry.
Apologies.
I thought I was in. Apologies. Is that better?
That is much better. Thank you very much.
So for treatments of or medical treatment with drugs for Raynaud's medication, they would be your next line option if lifestyle measures haven't worked and you're still getting increased in, or you're getting frequent attacks and painful attacks. And we would generally, what's the recommendations and guidelines and nationally is that we would use calcium channel blockers as our first line treatment option. And that's commonly, nifedipine is the drug that you'll most commonly see. There are other types of calcium channel blockers that you might come across called lodipine, philodipine or diltiazem, but generally nifedipine is the one that we use first line. It's in the UK, it's licensed and approved for Raynaud symptoms. And there's two formulations. There's one that's a quick acting that you can take 2 or 3 times a day, or there's a long acting one, which you can take once or twice a day. So generally people will start on the short acting or the quick acting one. But if you don't get on with that, and some people find that they get more symptoms with the quick acting ones, then there is the option to move on to the long acting ones as well. I think the main difference is that the long acting one is, it's not actually licensed for Raynaud, so it's an off license use, but we do commonly see it in practice where patients do use the long acting one. Because these drugs, all of them are trying to open up your blood vessels and cause dilation of the blood vessels or vasodilatory effects, you would expect side effects related to that vasodilatory effect, and we'll definitely, like usually we hear patients when they start treatment that you'll have headaches initially, sometimes a bit of dizziness and low pressure, but I think headaches is the one that people most commonly experience. And there's a couple of things you can do to kind of help with that. I mean, what we do is start low and titrate up the dose, so we wouldn't start you straight in at a high dose from day one. So you might start at a 5 milligram dose once a day, going up gradually to like 20 milligrams 3 times a day. The other thing that you can do is you can take simple analgesia. So things like paracetamol work quite well just for the headaches to stop them. So you may want to take them when you're starting the treatment to to stop the headaches from happening. Similarly, nifedipine it's a blood pressure lowering drug. So again, we started slow and titrate up to prevent people getting that low blood pressure and getting dizziness related to it. But it's generally quite well tolerated, but it's just on initiation we go slow and titrate up. The other side effects that people tell us that they experience is sometimes they get flushing, again related to the vasodilatory effect or opening up the blood vessels. And you also get what's called edema, where you sometimes get puffiness, like it can more often you see it like in the extremities, like in the ankles, that can occasionally happen with this group of drugs, but it's not all people. If nifedipine doesn't work, or if you don't tolerate it, there are other drug options available. So the ones that we would use next line if that doesn't work, or if it's not controlling the Raynaud symptoms, or you're getting side effects that can't be tolerated, we go on to a group of drugs called angiotensin II receptor antagonists, and these are they're quite commonly used as a blood pressure medication, and also in things like for heart failure treatment or for blood pressure management. But the way we use them in Raynaud's, or why we use them in Raynaud's, is because they block an enzyme called angiotensin, which it acts as a vasoconstrictor. So by blocking that, we're opening up the blood vessels, and so you get relief of your Raynaud's through that mechanism. So the one that's most recognized, or probably got the most experience with in Raynaud's, is losartan. but there is a wide variety of other angiotensin II receptor antagonists available as well. We also use ACE inhibitors, which are another similar class of drugs, and especially in patients with like scleroderma renal crisis, we'll see patients, there's good evidence to show that it protects the kidneys against that as well. So if you've got both, there might be a grounds for using those, using the ACE inhibitor group as well. It's the same principle for all of these. We start with the doses low when we titrate up. I think the side effects that patients most commonly report back to us, especially on initiation, although it's not as bad as it's not as bad as others, but because we do the start low and titrate up, but sometimes people feel dizzy as a result of that, and sometimes they feel a bit nauseous. So with this group, it sometimes helps because of the blood lowering effect. It sometimes helps to take it last thing before going to bed, so that you're still getting the beneficial effects, but you're not getting, if after taking it, you're not getting the same effect or dizziness when you take it, or you could prevent the dizziness if you lie down after taking it. We measure, just because this group of drugs can affect your kidneys, not in all people, it's just something we monitor for. So we periodically monitor the blood results, and what we're looking for is we look at the kills, so we just look at that and check it on the bloods. But for the most part, if you're maintaining a healthy diet and fluid intake, that's generally not a problem for patients. And if it is, we pick it up on routine monitoring. The other group of drugs, and they can be used they're sometimes used in combination with the losartan or the nifedipine because they work in a different way, but we have got experience of using the selective serotonin reuptake inhibitor called fluoxetine, which is also called, the brand name of it is Prozac, which people might be familiar with as well. But fluoxetine it's an antidepressant, but it blocks serotonin, which can cause vasoconstriction, and also which leads to platelet aggregation or pooling. So by stopping this, you're making the blood flow run a bit easier, and you're opening up the blood vessels. So that's why we use it in Raynaud's. The studies have been small, but they have shown some benefit of using it. And fluoxetine, it's quite well tolerated. Again, like some people, the people that have taken it report back that they sometimes get headaches or nausea, and they hear some people saying they get restlessness, which can lead to insomnia or them not being able to sleep sometimes. But that is generally, you see it when patients first start treatment, but overall I would say fluoxetine is fairly well tolerated. So then I'm just going to lead on from there. So that's looking at the Raynaud's medication. And I guess in a stepwise progression up, if these drugs aren't working, then we can look at alternative treatments, which leads us into kind of, I guess these drugs are recognized for Raynaud's and digital ulcer management, but we're trying to prevent the digital ulcers appearing in the first place. And also by improving the Raynaud symptoms, if that makes sense. So if your standard treatments aren't working, which are the ones that we have just mentioned, your calcium channel blockers, your angiotensin II receptor antagonists, and your fluoxetine, which is your SSRIs, then we tend to go stepwise up to the next groups of drugs, which the next one that we commonly see is phosphodiesterase inhibitors. So these are, there's quite strong vasodilators, or they open up the blood vessels by relaxing the blood vessels in that surrounding area. So the names that you'll commonly see, so we most commonly see sildenafil for use in Raynaud symptoms. I think sildenafil is a drug that's normally taken 2 to 3 times a day. We go, if we titrate up to the maximum dose, the maximum we usually or can prescribe is a 50 milligram 3 times a day dosing, but some people find that they get control of their symptoms or the benefit on lower doses. It is a strong, like it does lower the blood pressure quite a bit. So again, similar to the other drugs, we start slow and go up. So we would usually start with sildenafil, for example, at a 25 milligram tablet once a day for a week, and then go up by 25 milligram every week. So say week 2, you do 25 milligram twice a day, then going up to 3 times a day, and then we might increase the dose up if we're not getting the full response that we would like to see at that stage. So again, by titrating it up in that manner, we help to kind of control some of the symptoms that you get on increasing the doses up. So especially things like the blood pressure lowering effect and the headaches. So by starting them slow and going up, we can reduce some of those side effects. And same for the other drugs. If you are getting things like headaches in this period where you're starting the treatments or going up in the doses, you can take things like simple analgesia with paracetamol to stop the headaches and treat them symptomatically. Just usually, it's usually in the titration period. Once your body gets used to it, you find that you won't experience that side effect as much. Tadalafil is, I've put it on there, we don't use it as commonly in management of digital ulcers, but it is a once a day phosphodiesterase inhibitor, and it's sometimes helpful for people that struggle with taking medicines, say across the course of the day. If you're on a lot of medications and you're trying to time it around your day, sildenafil is one that you have to take 3 times a day, whereas the tadalafil is only once a day. So it depends on so it depends on as well as what locally you might have access to or what you have available through your rheumatology centre. If patients still have ongoing ulceration, or if they have or ongoing symptoms, usually Bosentan is used and is approved for prevention of digital ulcers. So this has been approved by NHS England, and it's a drug that was originally licensed for pulmonary arterial hypertension, but there's trials and data that are now that have supported, and it's now an established indication for use in the treatment of digital ulcers related to scleroderma. And how it works by reducing the formation of new digital ulcers by improving the blood circulation in the body. So it works it's been recognised, and that's kind of its place in therapy, is to prevent that stage where we want to prevent or stop or hold the progression of digital ulcers. So if so this is Bosentan is usually prescribed through a specialist rheumatology centre. So it's usually, I'll show on the next slide, it's usually where patients have unfortunately, for whatever reason, maybe not have tried all the other standard treatments and have achieved the maximum dose and might still be getting ongoing ulceration. Or if you have like side effects that are intolerable, that you have to stop the treatments, then Bosentan may be an option for if you've gone through the other treatment options. We usually hear patients that are started on this. It's usually at the start they get nausea and sometimes reflux. Also could get reports of headaches. But generally they get better the longer you take it, and the more your body gets used to it, they tend to go away. We also, Bosentan can cause abnormal liver function tests, and this is something that we monitor. And the risk is slightly higher when you first start taking it. So usually we monitor it a bit more closely on initiation, and then If we see that you're okay and your liver function tests are fine, then we can reduce the frequency of those blood tests that are required. And say, similarly with anemia, it's a rarer side effect, but it's something that we would monitor on the blood counts. And we will periodically do full blood counts or blood monitoring to detect or pick that up. So then the last group of drugs that I will talk about is the prostanoids, which they're an IV drug. So the two that we most commonly see are iloprost and epoprostenol. And these are kind of like a last line measures for maybe a couple of reasons. It's an IV drug where it actually requires admission into a hospital either as a day case or sometimes overnight, where you have to be available to have it over 3 to 5 days. And the infusions are usually at least 6 to 8 hours per day. So it is quite a time commitment, and not everyone is, that's quite I guess a time pressure to come in and be available to do that. It's quite a potent vasodilator, so people like quite often when the infusion is running, you get people reporting that they get like lots of headaches or get increased headaches, get nausea, and you can get low blood pressure. And usually with iloprost, when we have it running, we would usually say we usually stop patients' blood pressure medicines where possible while the iloprost is running. We tend to give painkillers or analgesia to stop the headaches, and also some anti-nausea medicines alongside the iloprost, just to make sure stop any of the symptoms from occurring. And I think usually we've got patients that they know when they're due their iloprost depending on when their symptoms happen, and it's really hard. You can have it up to every 6 to 8 weeks, but in reality, I think some patients only may have it just once a year coming into the winter period, and it covers, because it does last for much longer than the 3 to 5 days, and you can get up to 6 to 8 weeks of and longer of relief of the symptoms after taking it. So I guess what I'm saying is that, once a year might be enough for some people. Some people have to have it 3 or 4 times a year, depending on what they've tried and failed already. If this is kind of a last line measure, if this is what works for them, then it's just kind of titrating that to their response as well. I think I just highlighting on the next slide. So this is kind of a summary of the treatment pathway in Raynaud's, but also in digital ulcers. And for those of you that are in England, NHS England have recently updated the treatment pathway on this for access to medicines. And before, bosentan, which is now third line, used to be positioned after IV prostanoids. But because bosentan was on patent up until a couple of years ago, it's now gone what's called generic, where it's more freely, where a number of manufacturers can make it. It has reduced quite a bit in cost. So bosentan, which is an oral drug, will come ahead of IV prostanoids as a treatment option for digital ulcers. And a benefit of that as well is it's coming because it's coming before the IV prostanoid. It's another oral option that's available before having to come into the hospital for IV iloprost, and that's hugely beneficial for patients, I think. And bosentan works quite well as well. So that's my, and hopefully we'll pick up, and I'm sure you'll have questions as well for me afterwards, but that's just a summary of the drug treatments that are used in Raynaud's and digital ulcers. And then, I don't know, so Barry, do we want to take questions now or move on to do that at the end?
Is the presentation finished? Are we ready to move on to the next section?
No, I think maybe if we do all the drug treatments and then we can take all questions at the end, if that's okay, whatever.
I think that's best, if we go through everything and then we can leave questions exclusively to the end.
So then I'm moving away from Raynaud's and digital ulcers drug treatment to slightly different targeted therapy. So this so a lot of the drugs are so the systemic immunomodulatory drugs are the aim of the treatments are to dampen down the immune system in the body, and therefore they dampen down the inflammatory response. And we get inflammation in scleroderma for a variety of reasons, but the main aim is to stop any damage or any progression on the organs that might be affected. So we know in scleroderma that we can get lung complications, we can get pulmonary, we can get lung complications, we can get skin, where you get skin thickening, especially in diffuse scleroderma, which can affect the internal organs. You could get inflammatory joint problems and myopathy, where you get muscle inflammation. And the idea is to dampen down that inflammatory response, so we're stopping the damage to those organs and preventing complications at a later stage. So the group of drugs that we will use to do that, so we use steroids commonly, but that's usually in an acute phase, and usually they're usually a short-term measure, treating an acute flare, for example. But steroids are not a long-term solution. If you and they are associated with a variety of side effects. You can get bone complications or osteoporosis. They can increase your risk of diabetes. So while they work very well and people will be on them as a short-term thing, we try to prevent or minimize the duration and the dose of steroids that you're on to prevent long-term complications. So drugs that we use as an alternative to steroids, or even alongside it while we're trying to get control of the inflammatory response, are drugs called disease-modifying anti-rheumatic drugs. And these are a group of drugs. There's a variety of them available, but they will be targeted. It's very much individualized because it's going to be targeted to the disease manifestation that you're experiencing or the organ affected. But it's the same principle. We're trying to dampen down that inflammatory response to prevent organ damage. So say, for example, if you have got lung complications, we sometimes use mycophenolate, or we might use IV cyclophosphamide, which is a potent DMARD or anti-inflammatory drug to dampen down the immune response. We also sometimes use methotrexate with if there's a skin involvement and we're getting skin thickening. And similarly, azathioprine is also used for skin, but can be used for lung complications as well. So these will be individualized. They'll be start by a specialist in rheumatology. Some of the drugs are allowed to be transferred to GPs for prescribing, but these would always generally be started by a specialist in scleroderma or in rheumatology to begin with, to help with the initiation of the drugs. Because they're immunosuppressants and because we want them to dampen down the immune response and that inflammatory response, but at the same time, because they're immunosuppressants, they can make us more susceptible to infections. So generally, before starting these drugs, people will be screened for any infection risk to begin with. So that might include things like they might check that your vaccines are up to date. They might do screens for things like hepatitis B or C to make sure we've identified any risks for infection to begin with before starting immunosuppression treatment. The other thing is they're generally quite well safe if monitored appropriately, but you will find that if you are on these drugs that you will be asked to have routine monitoring of things like your liver function, your kidney function, and your full blood counts to make sure they're still safe and you're on the right, and they're not inadvertently affecting, or you're not getting inadvertent side effects that we don't want. If we still there is I guess new more specific therapy called biologic therapy, And these become more specialized, and it depends on what your, they're very much targeted treatment depending on what your organ manifestations are, or how your disease and symptoms are presenting. But we sometimes use drugs called rituximab and tocilizumab, and they generally require you to come into the hospital to have treatments. And then we also use a drug called immunoglobulin, which is, it's a plasma-derived product, but it's also used to dampen down the immune response. But it's reserved for specific indications. We quite commonly see it in patients with myopathies or inflammatory myopathies because it works well in that group of conditions. So these these are, I guess that's a very broad overview. And if you're started on these drugs, you will be given more information by your specialist teams as well. And there's a lot of information out there, say on Arthritis UK and even on SR UK have excellent resources. And it's just, if you do have questions, like your specialist pharmacists and rheumatologists are in a good position to help as well. So the other complications that we get quite commonly see in scleroderma are, and I think most of our patients will have got complications or excessive acid reflux. And the evidence, there's not strong evidence, but from practice and from experience, we find that the PPIs, which are proton pump inhibitors, are things, and the names that you commonly see are things like omeprazole, pantoprazole, lansoprazole. That group of drugs are probably the most effective at actually reducing the acid secretion and reducing those symptoms of reflux. We do have also H2 receptor antagonists, but as any of you that might have been on them before will probably know from the last 12, 18 months that we've had widespread shortages of this group of drug. So we've had to do a lot of chopping and changing depending on what we've had available. There's nothing to say that one group is better than the other. I think the main problem at the moment is availability. So if you are struggling with that, just speak to your pharmacist, your community pharmacist and your GP, and you may need to just be a bit, may need to be open to switching between different preparations in order to get one that, that is available and works. We quite, because the acid reflux can be so severe, we do commonly, or we used to at least before we had the shortages, we would commonly use the PPIs and the H2 receptor antagonists in combination. And that's not a problem. And generally we find that people do need to stay on these, and they need to kind of go up and down on the dose depending on their symptoms. What I will say with the long-term use of the PPIs, the omeprazole, lansoprazole, things like that, it can predispose you to things like getting low magnesium levels. So they need to be periodically checked. And the other one is sodium levels. And these are commonly, like these are commonly, can be picked up or seen on your blood results as well. So it can be checked through that mechanism. We use similarly with gut scleroderma, you can get diarrhea, or you can get so then we're just or you can get the opposite, where you can get sorry, can help with so you may need to take medications like laxatives to help with diarrhea, or medications to stop it, which would be loperamide. And then the other common symptoms that we hear people talking about or explaining to us, like that they get this feeling of bloating, or that they feel full after not eating a whole lot, and you get gut motility problems. And for like early like when you feel like you're really full early, or you get bloating or motility, we use a group of drugs called prokinetics, and they're things like you can use like domperidone, metoclopramide, erythromycin. But if you do have those symptoms, it's probably best to talk to your GP, because then they'll look at the whole picture and see what's actually the best option for you. And there may be things to explore before going down the route of taking drug therapy as well. And then in terms of skin or complications, we do get, we do see patients, like I guess in terms of with your digital ulcers, but we also see calcinosis. And I am fortunate enough to work with really good nurses who have excellent, like, so whenever I've got patients asking me about the skin complications or what's the best cream to use or the best dressing, to be honest, I usually check with them as well. But I think the main things for things like the calcinosis or to prevent it occurring even in the first place is to use the emollients and skin moisturizers, which have that are more on the greasy side or kind of thicker ones. So ones that contain lanolin, but the ones that you'll see that are available to buy are things like Cetraban is a quite common make, the white soft paraffin and liquid paraffin 50/50. But to be honest, there is so many available on the market that it is sometimes a case of trying and seeing what works best for you. And I know some centres have, they can provide some samples where you can take away 4 or 5 samples and you can have a try and see which one is working best for your skin. I think the other thing with calcinosis is that what we're trying to prevent what we're trying to prevent is infection. So by looking and by highlighting and looking at that early and looking for signs and symptoms of redness or increased pain, you might want to get that checked out earlier to make sure it isn't an infection and that you might need antibiotics for. But if you do experience that, you will probably have to go to your GP or someone to review that. Very quickly, I'll just talk about other considerations, which will be difficult to go into in detail in this presentation, but there is resources available and your pharmacist and rheumatology team will be able to signpost you as well as to where it's best to check for information. But I think overall, if you're thinking about medicines and practical things about managing your medicines and Raynaud's and Scleroderma, I think always if you're thinking about becoming pregnant or you have questions around breastfeeding, there is options for medicines that might be safer. There's advice that we can give you, but the best thing is to talk to us in advance and we can plan and give advice further. The more we know about it and we know about your plans, the better we can inform you and kind of make choices with you about what the best options are. Now, similarly with so formulations and swallowing difficulties, a lot of patients with gut scleroderma may have issues with swallowing tablets whole or capsules. And there's, I think, broadly speaking, most of when you use tablets or medicines, there can be medicines that have lots of different preparations or formulations. You might have to get a medicine that's available as a tablet, a capsule, a liquid, and you've got options and you can change quite quickly to a liquid. But for the most part, not all tablets do have a liquid preparation available. But we can give advice about actually whether that tablet is suitable for crushing or breaking into smaller pieces to be able to take it or to help with swallowing difficulties. But again, not all medicines are suitable for that. So you will probably, the best person to speak to about that is your pharmacist or your specialist or your GP can help as well, and also your specialist rheumatology team. Because we've got experience with this. We can advise if there's other formulations available. We can advise if that tablet that you're on is suitable for crushing or dispersing or taking to a different route. I haven't touched a lot on herbal and alternative treatments. The SRUK website has got a really good resource on alternative treatment or on herbal treatments that can be used for Raynaud's. So I would suggest you check on there as well. What I would always advise with herbal or alternative treatments, I think there's sometimes a misnomer to say because they're a natural treatment or they're a bit herbal that they're going to be safe. They can interact with prescribed medications, so it's worth checking that out before you start taking or changing anything. And again, your pharmacist can check that for you if you've got any concerns. And then Also, your pharmacist is really well positioned. I know we've talked a lot about Raynaud's and Scleroderma, but you will be on medicines for other conditions that you've got diagnoses of, and it can get a bit overwhelming with the number of tablets, when to take them, how to take them. So it's worth having a chat with your pharmacist to actually sit down and say, right, this is what I'm on. Is there anything particular that I actually have to take this at a specific time, or I have to take this with food or after food? You'll probably find that actually there will be an optimal time, but the main thing is actually working it around your lifestyle, because at the end of the day, you're going to have to take them, and they have to work with your routine. And it's more important generally that you take them than don't take them. But your pharmacist is in a really good position to talk you through that. If you've got one attached to your specialist team, well and good, but a community pharmacy can also help with that as well. I think that's all for me. I'm sorry, I feel like I have kind of skimmed over topics, but I'm hoping some of the issues or some of the queries will come up on the Q&A session. So I'm happy to take your questions through that way. And if we run out of time, I can pick up on it afterwards as well.
Thank you so much, Aoife, for the amazing presentation. I'd now like to direct everyone to hover over the Q&A section on Zoom, and you can put in your questions there, and I can then put those questions to Aoife. We do have 15 minutes left, so we'll do our best to try and answer as many of those questions as possible. Some questions have already come in, so let's take a quick look at them. So we've had a question coming from Rachel, and Rachel asks, is there any harm in frequent use of heated gloves to keep fingers warm? So are there any issues with using those gloves, or any side effects of using them too much potentially?
Sorry, which gloves?
Heated gloves.
Heated gloves.
Yeah. Is there any harm in frequent use of heated gloves to keep fingers warm?
No, I wouldn't have thought so, Rachel. I think it's responding to your symptoms and what's keeping your symptoms under control. But I mean, check this product specification as well, but I wouldn't have thought so. I think it's about controlling. It's a device, and it's about controlling what's happening with your condition. I would say, and if it's keeping them at a temperature that's keeping your symptoms under control, I don't think there's any problems with excessive use, if that makes sense.
Thank you, Aoife. Rachel also goes on to then ask, is there harm in non-gentle exercise?
Non-gentle exercise? No, I think it's about what you can tolerate and so I think when I was saying gentle exercise, it was actually getting some movement. It's about checking what your body can tolerate as well. So no, I think what would I say? I think it's just maybe avoiding the trauma which might trigger the Raynaud's, or if you're going into I don't know, extremes of temperatures, if you're swimming and going into a cold area, then you might want to be a little bit more aware that can trigger it. But I think it's about responding to your body as well.
Thank you, Aoife. We've had a question coming from Pat, and Pat says, I have problems tolerating drugs. I have PAH and have really bad symptoms from the drugs prescribed. Yeah. Is this usual?
It's hard to say. Everyone reacts differently to medicines, and even when I talk about side effects, you're talking about a very general population. So everyone does react differently. So I'm sorry to hear that you are actually having so many issues. It is really tough, and it might mean that you actually have to swap between different medicines to find the right one more frequently, which is frustrating in yourself because you're trying to find something that's actually going to treat your condition. I would say it's difficult without going into the detail of the specific medicines, but you might want to sit down with, if you've got a pharmacist attached to your PAH team, or a nurse specialist, and sit down and go through the medicines and see actually, is there common themes, or is there, because I mean, if you've got your PAH related to your Scleroderma condition, sometimes unfortunately you do get the GI symptoms a bit more, and a lot of drugs do cause GI symptoms, especially when you start taking them. And it's maybe thinking around routes, if you're starting a new medicine, is there something that you can take in addition to help with that particular side effect you're getting? If it's sickness, you can take an anti-nausea tablet, or if you're getting increased reflux, you might have to increase your PPI for a period. Yeah, I know that's very general. I think you might want to sit down with someone to go through your PAH medicine and see what's happening. And also they'll be in a good place to see what they can offer as well, as in what the alternatives are.
Thank you so much, Aoife. We've had a question coming from James, and James says hello. He says, I heard that sildenafil can, sorry if I've got that wrong, can lower the blood pressure. Why do they not ask us to stop it when having elaprost, like they do with perindopril?
I think was that sildenafil.
Yeah,
so
that's the one.
Yeah, so we would generally stop it. I think the one area you would not want to stop it if you're on it for another indication, because sildenafil is also used for pulmonary hypertension. And I mean, the other thing to bear in mind is some people get more of a drop in. I think, like I was saying, everyone does respond differently. So some people may get more of a drop in their blood pressure when they're on the iloprost than others. So that if your team think that you're tolerating it okay, they might actually decide to continue with them. But it's worth talking to them as well and seeing what their views are on it. I know we have got patients that do stop it when they're on the iloprost and no harm has come, and then they just restart it when they stop the iloprost. But it might be worth chatting with your team as well and see what their views are on it.
Thank you so much, Aoife. Shirley has asked, what symptoms is hydroxychloroquine? I always struggle with this one. What symptoms is it specifically aimed at?
Hydroxychloroquine. So it can be used for, we see it probably most commonly for joint symptoms, but it can also be used for skin as well. It is that group of drugs called a DMARD, but it's not probably as immunosuppressive. So you get less risk of infections and things like that. So it modulates the immune system, but it's not as immunosuppressive. So it works in that way. But it works for joint pain to kind of dampen down the inflammation around there. So you'd see actually, if any, like people, we quite commonly use it for rheumatoid arthritis. It's quite a safe first-line drug. But in scleroderma, we also use it sometimes for the skin manifestations as well.
Thank you, Aoife. A question is coming from Becky, a bit of a complicated one, but it says, what is the impact of immunosuppressants on the COVID vaccine?
Very good question. I haven't actually talked much about COVID in my talk, I think probably because everyone's been talking about it. So we know that, and we're getting more and more information. I think there was a lot of, I think, anxiety even for us treating patients at the start and not knowing what the effect of like patients being on immunosuppressant and what that was predisposing patients to COVID. I think we know now that it's quite important that your disease is under control, so we wouldn't advise stopping immunosuppressants because of the risk of COVID. And we would definitely recommend that people have the vaccine where it's offered, and I think most people will have had that opportunity now. Or if you've got concerns about the vaccine, to talk to people and talk to your rheumatologists. There's probably more information coming out about which drugs are, because across the DMARDs and immunosuppression we have available, there's still like some are more immunosuppressive than others. We are fine. I think there's more information about rituximab, and they're saying that it's quite important to have your vaccine before going on to rituximab because that can dampen down, because it's got quite a long effect, because it's an every 6-month drug, that the effects of it can hang around for a while. So you're lowering the immune system over a period. So there may be an increased risk associated with that, with the duration of action. So I think it's still evolving. I think there's still information coming on it, but we know it probably does predispose, but not probably to the same degree that we thought initially. We're getting more information on the individual drugs each time. And I would say, yeah, prevention is the idea. So like taking the vaccine and making sure you have that if it's offered. Does that answer the question? Sorry, I kind of...
Yeah, no, it is a very complicated topic. I think you've done a very good job there, Aoife. I've got another complicated one for you, I'm afraid. It's from Sarah. And Sarah says, I've recently been diagnosed with diffuse scleroderma. My rheumatologist is going to put me on my coffinolates after I've had the necessary tests.
Yeah.
Last visit, it was mentioned I'd also be put on steroids, the dose hopefully reducing, for at least 3 years. I'm a bit concerned about the steroids and would welcome your thoughts.
Yeah, it's always a balancing game with the steroids, because and I'm sure your rheumatologist will talk to you about this as well, but we know we have patients on it that need to be on them. We're always trying to minimize the dose that patients are on or need to take them. Sometimes, like they do the job very well, but unfortunately they do come with side effects. I think if you are on them long term, just to ask your doctor or whoever's prescribed, your rheumatologist that's prescribing them, to think about things like you can think about your bone protection. So sometimes they'll do a DEXA scan to check your bone density, and you may need treatment to prevent that if you're on steroids long term. I think that's the main risk. If you're diabetic, to make sure your diabetes control, because steroids will increase your insulin requirements or your diabetes medication requirements, and so just make sure you're monitoring that more rigorously. I think the main thing in our group of patients who are in scleroderma is that thing around bone protection, so making sure that's checked out. And sometimes making sure your diet is adequate for calcium and vitamin D. Again, they're things that can be checked on blood tests, and you can take supplements, but I would say talk to your rheumatologist in the first place, and they can guide you on that, because it depends on the dose you're on, how long you've been on them, as to where your risk probably lies in the first place.
Thank you so much, Aoife. We've had an anonymous question come in, and it says, I've been taking linaclotide for my gut issues due to scleroderma and the medications I was placed on. Is this a medication you would recommend for scleroderma patients?
I don't know very much about it. I think we've not used very much of it, but it might be more in the gastro-specific setting. So I don't think there's any reason why we couldn't give it to scleroderma patients, and if it's working to treat your condition, that's fine. But I would just, sorry, I'm not very familiar with the drug, so I don't want to give to say something that I might be incorrect about. It might be worth just running it by your specialist as well. I'm sure they would have. Like I said, I don't think there's any reason why it wouldn't work for scleroderma related issues.
Thank you so much, Aoife. Another question has come in, and it says, how does PPI medication cause changes to magnesium and sodium levels?
Good question. It's not entirely sure. We think it's probably something to do with the interface of where it works in the gut, because it works on like an ATPase kind of the mechanism in the stomach. It's not. It could also be related to the acidic, because we're reducing the acidic environment in the stomach, so might be reducing some of the absorption. Not necessarily for sodium. This is more the magnesium. Might be reducing some of the absorption of the magnesium in the gut as well. It's because we've used PPIs for years, but it's something that's kind of, we definitely see the sodium, like we do see hyponatremia related to it, which is low sodium, but low sodium can be caused by lots of things. So it tends to be more an additive effect with something else happening as well. The magnesium, we do see it tends to be on long-term use and high doses, which that's what we do use in scleroderma. And again, it's definitely not a problem for everyone, but it can be a cause of hypomagnesium. So if it's a persistent problem with the magnesium levels, then we may have to look at alternatives for the gut manifestations.
Thank you so much, Aoife. We do still have a number of questions, but unfortunately we've run out of time, so we will do our best to see what can be done to answer those questions. But again, I'd like to say a huge thank you to yourself, Aoife, for that amazing presentation and for answering those questions. It's been an absolute joy having you on. And I'd also like to, of course, thank our audience for their support and their participation and for making the session what it is with your amazing questions and your continued support and involvement. I'd like to once again remind you all, if you are enjoying these webinars and you'd like to see more of them, you can donate, and you can do so by texting SRUK webinar to 70450, and it's within the chat function. So if you'd like to find out more information about that, you can head over to the chat function and you can see that information. I'd also like to let everybody know that we're having our virtual conference in September, and I'll post the link for you to all sign up to that. Let me just get that added into the chat function really quickly. So our virtual conference link has just been put in the chat function, and it would be great to see you all there. But lastly, I'd just like to thank you again, Aoife, for that amazing presentation and for helping out.
Thank you for having me. It's been, yeah, it's nice hearing everyone's questions as well. It's been really helpful.
Fantastic. And I'd like to apologize again for those that who we haven't been able to answer their questions, and we'll see what we can do in the background to try and get those questions answered. But again, a huge thank you. It's been an absolute pleasure having you on, and our community have already shared quite a lot of feedback during the webinar saying thank you for your amazing presentation and for answering those questions. So I'd like to wish you all a lovely rest of the day and a lovely week ahead. But we're now signing off. So take good care, everyone, and take care, Aoife. Bye-bye.
Thank you,
everyone. Take care.